One of the things that you go to meetings like this and all you see is CAR-Ts, bispecifics, trispecifics. The drugs are amazing, but they require a couple of things, especially when you're using them in heavily relapsed patients. Number one, in order to get on clinical trials, you have to fit inclusion and exclusion criteria. And many of our patients are reaching third, fourth, fifth, sixth line with marrow compromise, and they're not eligible for the studies. And or maybe their T cells are a little bit exhausted, or they don't have the time to wait for manufacturing of T cells for things like CAR-Ts. So one of the things that we did is looked at patients who were otherwise fit, but were having marrow problems, and gave them classical chemotherapy regimens like DCET, VD-PACE, melphalan and BCNU, below the myeloablative doses, so nothing more than about 100 milligrams of melphalan. And we gave them stem cell support after, so it was kind of, we called it a boost, not a full transplant. And what this allowed is, number one, it debulked patients rather quickly, and it led to marrow recovery. And although the duration of the remissions was not terribly long, we're talking around 3-4 months on the whole, it was long enough to bridge people and then now make them eligible for clinical trials and other studies and other treatments. So it really is not, it's not the answer, but it's a bridge to getting them to all of these amazing new therapies. So I think our lesson is, there still is a role for some of the old drugs in myeloma as a means to an end.